promoting me to the Master of Public Health. I'm still a student. Good afternoon once again, ladies, gentlemen, and others. I've already been introduced, but I just want to acknowledge the presence of our senior colleagues in the House. I feel nervous, but I will try my best to go through my presentation. So I also want to acknowledge the authors or the co-authors that you are seeing from the screen, from the Zimbabwe Health Interventions, from Ministry of Health and Child Care at all levels, and from the USAID, who is our funder. So from the screen, my presentation is entitled Understanding the Geospatial Distribution of New HIV Infections Using Recent Testing in Berengwa District and Reporting the Lessons Learned. So this is the overview of my presentation. I will take you through the background, our objectives, our methods and discussion points, conclusion and recommendations that we've learned from this study. So just as a brief overview, background again on our organization, is we're implementing the ACE project, Accelerated and Comprehensive HIV Care for Epidemic Control in Zimbabwe project. So this is a project which has got, in terms of activities, it has got 5 main domains, which we can see from the screen, from HIV testing services, from linkage to care and continuum for care for recipients of care living with HIV, TB and HIV collaboration, the use of data to inform public health response, and monitoring of viral load towards viral load suppression. So in the interest of our time, I'm just going to be zeroing down in terms of our HTS and our SIE domains, which also speak to recent testing. So this background, I'm sure most of the people have already alluded that to. The background according to the Joint United Nations Program for HIV and AIDS, SB 2020, there have been a lot of progress in terms of the 1990 progress, which was the 2020, towards the 95, as we are pushing to 2025. So from this progress, we can see from the graph there that we have had our first 95 lagging behind. Even in 2020, we had not managed to reach the 90% of people living with HIV knowing their status. And from what we have, mostly the males were actually lagging behind as compared to females. So in terms of HIV incidence, as a 2020, according to the Zimbabwe based HIV impact assessment, ZiMA, a report of 2020 shows that the incidence was at 0.38%. And as at present, I'm sure you heard from the previous speakers that it has gone down to about 0.17. So the prevalence in terms of the adult population stands at 12.9%. And as a project, it has been our interest to also look at the new incidences, which is the 0.38%, with the contribution of 0.54% from females and 0.20% from the male counterparts, to look at that number and also characterize in terms of how recent the infection has been. So in Berengwa, which is one of our implementing districts, we've managed to look at that particular data, which is actually from the period of October 2022 to March to June 2023. So Berengwa is also implementing a recent testing, and the recent testing started after the rollout, which was around 2019 for the Midlands province, and it has managed to scale up to most of the facilities. And as at March 2023, we have reached about 32 facilities of the reporting 34 facilities. So all the clients or all the recipients of care who test positive for HIV go through the testing for recent testing, which is a rapid test using the Asante HIV-1 antigen antibody immunoassay. So with this particular assay, we use it mainly for the 15 years and above, because for those with 14 and below, the test has not yet been validated. So a positive recent test would imply that the infection was acquired within the past 1 year, and the negative will imply imply that the infection is classified as a long-term infection. This has not been just as part of the project as ACE, but it has been also as part of the national case-based surveillance that has been rolled out by the Ministry of Health and Child Care. So in terms of the objectives in this particular study and implementation of recent testing, we want to support a multitude of these approaches that support HIV surveillance, not only limited to recent infection, but also limited to high viral load clusters, mother-to-child transmission data, data on advanced HIV disease, among others. To also determine the characteristics of the population with the recent infections in terms of where they come from, in terms of their ages, in terms of their activities, and in terms of their gender. Lastly, also to ensure that we use that particular data to identify the gaps that we have as a program, and also to ensure that we use that in actually informing public health response, at the same time safeguarding the human rights and also protecting the vulnerable. So from our methods there, I just listed what we have been doing, but as a study, this one would actually fit in as a cross-sectional study using the secondary data that we've captured through the DHIS2 system. So what we did is that we had recent testing data captured in facility registers, and then this one was later on captured in the Ministry of Health DHIS2, and also the program data database, which is the ZHI DHIS2 database. So we also conducted a weekly analysis and review of the HIV recent data, disaggregated infections by subpopulation, by geographical area using the GIS packages. So we also identified potential hotspots of the new infections and made sure that our responses were also targeted from the data that we got from the recent infection, as well as triangulation with other data sources that we have. So in the period under review, Mberekwa district recorded 875 new positive infections, and of those infections, 527 managed to have a recent test done using the Asante kits, and of those 17.8%, which translates to 94 of them, had a recent infection positive. So this one now is a spot map that is showing us the distribution of these recent infections. So as we can see from this map, I'm sure my pointer is okay. So, but those who are close by, I'm sure you can see the difference comparing our legend there, which is on the footnote. There are districts there on the far left. We've got Mberekwa, which is the Mberekwa District Hospital, and then we also have GA, which is one of the facilities. And then on the far right there, on the top of the map, we also see that there is one clinic which is also called Neta Clinic. So what we noted from this data is that these three sites, they contributed to 38% of all the recent infections in the district. And as a follow-on, we also managed to ensure that there's response or a cascade of care to those particular sites. So having that geographical spot map of three facilities contributing to 38% of the recent infections, we also zeroed down to then look in terms of age. So from the graph that you see there, the blue bar is just showing us the number of people who were tested for recent, but the one which is brownish there is actually showing us those who actually recent positive. Of note, we've got more recent testing amongst the middle age group there. But in terms of the actual proportions of recent infections, we can see that from the far left there, 43% of the 15 to 19 age group contributed to have more recent infections, which also gave us more questions as to why that distribution is in that particular order. So I'm actually now showing the table, which is now breaking down the characteristics in terms of sex and again in terms of age. So from what we observed from that graph, whereby we had 43% of the teenagers living from 15 to 19 age group having 43%, we also see that there is a female predominance, whereby for almost all the age groups there, we see that the female counterparts were actually high in terms of acquisition of recent infections from the 15 to 19 young girls, and from the young mothers 20 to 24, we continue to see that they were much higher in terms of contributing to acquisition of HIV. So this one is a graph that actually shows part of the interventions that we've done as a project. This is a cascade which is showing us PrEP initiations. What we see there is just the absolute figures in terms of initiations over the same period. But in a summary, we've got a pie chart that we actually put there to show our concerted efforts towards the 3 clinics, which is GAA, which is the Neta, and the Belengwa District Hospital. So those the clinics in the period under review, they managed to contribute 21% of PrEP initiations, which is the oral pre-exposure prophylaxis for HIV. So in a conclusion, we actually noted that the recent infection data is critical in actually tailoring our interventions towards certain age groups. But we also noted that these infections were concentrated in the mining activity areas. So if those who know Mberengwa, you know that areas around GAA Clinic and areas around Neta is by the road to Blawayo, which also even has got some shelters for sex workers. And the reason why it is like that is because of the high volume of artisanal miners. Where there are minerals, there are artisanal miners. Where there are artisanal miners, there's a bit of money. And as we all know that when sodium is, water also follows. So those are some of the issues that actually came into play in some of the findings that we actually made. But from Belengwa District as a hospital, we also noted that it is a catchment area of around 10,000, and it also caters for the whole the whole district. So all the activities or all the people who are in the district, they actually then migrate and move to the district area or the growth point area where those activities or the behavioral issues which cause the transmission of HIV would be occurring. And then we also noted that recent data it can also help us to inform design and implementation of future HIV prevention models. But as a recommendation from what we have, we also had recommendations to ensure that as a partner, together with the Ministry of Health and Childcare, we need to also triangulate with other data sources before a full scale-up of interventions. This also includes high viral load clusters, because with the high viral load, we also expect high transmission of HIV and high recent infections. We also noted that we also need to also look at other data, especially the mother-to-child, to also maybe see if the transmission amongst those who are pregnant is also uniform, as we see from the general population. So implementation of targeted interventions should also be towards the priority populations rather than a large-scale intervention, which is a one-size-fits-all kind of approach. We also noted that we need to scale up the HIV sense testing to all the facilities. In the case of Mberengwa, we are left with only 2 facilities, which is Mazwofa and Onda Clinic, which contributes to about over 10,000 in terms of catchment area. We also recommend that we continue with the adherence amongst our recipients of care who are living with HIV and are on ART. As you have noted that during the same period, the project efforts made sure that the district has got a suppression rate of over 95%, and for Mberengwa, it was at 97% suppression rate. So, and lastly, we also support the rollout of the DREAMS program, which is a program which supports the young, the adolescent girls and young women in terms of preventive services. Given that the data that we have shows us that there are more recent infections amongst the 15 to 19 age group. So it's a project that we are also supporting on one of the wings of the organization, which is also coming through to Belengwa District. We've not exhausted everything, but I would just want to quote from Dr. John Kengason that we shall strive to know and we shall close our gaps in the future. I want to acknowledge the United States Agency for International Development, USAID, Presidential Emergency Plan for AIDS Relief, the PEPFAR, for supporting Zimbabwe health interventions in making sure that the project goes on smoothly without hiccups. I would also want to extend my gratitude to the Provincial Medical Director, Midlands in absentia, the Minister of Health and Childcare at all levels, Zimbabwe Health Intervention Program staff, and our recipients of care.
Thank you very much, Doc. I would like to acknowledge you for the excellent recommendations. I think everyone